morning, everyone. Firstly, I have thanks to the organizing committee to inviting me to this great congress, and I am carrying best regards from the Egyptian Ophthalmological Society to all of you. Today I'm going to speak about the addressing the ocular surface disorder in laser corneal refractive surgery. We all know that the ocular surface system is in a constant dynamic equilibrium, always adapting to changing environmental and external insults. With refractive surgery, transaction of corneal nerves during incisions that leads to neuronal destruction, preservative of medication used during and after surgery, epithelial cell changes, all may contribute to ocular surface inflammation and dysfunction, which leads to dryness. This is the vicious circles that we facing in refractive surgery, from neuronal destruction, apoptosis, inflammation, which leads to ocular surface inflammation. According to 2018 statistics, shows that more than 40 million patients had LASIK surgery since 1991. Symptoms of dry eye are found in 50% of patients who had LASIK after 1 week post-operative, 40% at 4 weeks post-operative, and from 20 to 40% at 6 months post-operative. The influence of dry eye disease on quality of vision leads to discomfort and eye strain, blurred vision, fluctuation of vision, which affects patients in nighttime driving up to 35%, reading up to 30%, and computer working and watching TV from 20 to 25%. We all know the corneal nerve distribution in the superficial stromal layer with horizontal distribution. Iatrogenic corneal nerve damage by photoablation interrupted the lacrimal flange. Surface laser vision correction directly severs the epithelial subbasal nerve plexus, anterior stromal nerve fiber, depending on the depth of ablation. Flap-based ablation, like LASIK, directly cuts the main corneal nerve fibers passing from the limbus, except at the hinge size. So we see that PRK ablation zone and depth play important role in affection, while SMILE, the incision size in LASIK, the LASIK flap and hinge size and site play important role in this way. And refractive surgery, the effect is directly on the corneal sensitivity and the corneal epithelial barrier, tear film secretion, and tear film stability. Patient who has underwent PRK had a lower incidence of dry eye than those who underwent LASIK, although studies showed that PRK also negatively affects the corneal nerves. So the impact of refractive surgery on OCD leads to reduction of corneal sensitivity, neurotrophic epitheliopathy, change of corneal curvature. This is a schematic chart shows the effect of LASIK, which leads to disruption of the intracorneal nerves, damage of the goblet cells by suction rings, altering of the central corneal shape, all leads to decrease of tear clearance, ocular surface damage, and tear film stability, which leads to dry eye. Recovery of corneal sensitivity begins 4 to 6 weeks, completing at 6 to 12 months after LASIK. The subepithelial plexus and Bowman's layer are recovered in well-done flap in about 2 to 3 years. While in PRK, recovery of corneal sensitivity begins 4 to 6 weeks, completing at 6 to 12 months, and also subbasal nerve density returns to preoperative level at 2 to 3 years. This is a confocal comparison of corneal nerves regeneration and keraticized reaction between femtosecond laser and irregular LASIK. We can see that there is no big difference between both techniques, while there is a great difference between femtosecond LASIK and SMILE, because the small incision that's occurred with a SMILE. According to the dry eye working shop, they grading the severity of dry eye, of the symptoms and signs of dry into 4 grades. LASIK surgery adds to the patient at least 2 levels that transfers the patient from grade 1 to grade 3 or from grade 2 to grade 4. That's why our patient always asking, what about my dry eyes after LASIK surgery? And there's so many reports about suffering of patient and even suicidal attempts after LASIK surgery for the dryness. So the preoperative risk factor of patient with ocular surface disease is breakup time less than 10 seconds, Shermer less than 10 millimeter, long-term contact lens wearer, female gender, age more than 40, and Asian gender also. So the preoperative patient questionnaires that we have to do before refractive surgery, you have to ask the patient, do you feel dry, pain, sore? Do you experience episodes of period of blurred vision? How often your eyes sensitive to light? Do you have problems with your eyes during watching TV, computer, and mobile? Do you always use artificial tears? Do you use contact lens for a long period? Patient who answers yes to any of the previous questions must be examined and evaluated for dry eye disease. All OECD should be investigated, examined, properly managed before considering keratorefractive surgery for any patient with many diagnostic tests like breakup time, Shermer test, Rosenberg, whatever we have to do. The preoperative assessment and preparation for patient with OECD who will do surgery, LASIK is not indicated if the preoperative treatment did not decrease the ocular surface inflammation, restore the integrity of tear film, recover the corneal sensitivity. So we have to think of another alternative like ICL or refractive lens exchange, or we will face with exacerbation of symptoms of dry eye, delayed healing, unpredictable refractive outcome, fluctuation of vision in patient dissatisfaction, persistent neurotrophic keratopathy and post-operative ulceration due to nerve damage, risk of corneal melting and perforation, risk of infection with MGD. Post-surgery treatment can worsen the condition due to use of preservative, non-steroidal anti-inflammatory, and steroids. The post-operative surgery treatment of OECD, artificial tears are initial therapy with the use of preservative-free drops should be encouraged, especially in sensitive post-operative eyes and in cases with patient use drops more than 4 times a day. We have to know the component of the tear substitute according to the layer that we have the deficiency, cellulose derivatives for lipid and mucus deficiency, polyvinyl alcohol for aqueous deficiency, and sodium hyaluronate for any layer. In severe resistant cases, punctal plugs should be used, and if artificial tears are not effective, it can be temporary or permanent. Autologous serum eye drops are also considered for treatment of post-LASIK dry eye. So finally, management of post-operative ocular surface disorder improves the patient life and vision comfort. Like we see here, this is a case of dryness, and topography, we can see the topography is very affected, and the patient blurred vision, but after treatment he regained his topography and he regained his vision. So it's very important to deal with the normal patients that he will have a dryness, and with OECD patient that we have exacerbation of the dryness, to have him as a good vision with refractive surgery. Thank you for your attention.
Thank you so much, Dr. Medhat. So as when you're evaluating your patients in the clinic for refractive surgery, is there any particular test that you always do to rule out a presence of an OSD other than the slit lamp evaluation? Like, is there anything?
Yes, breakup time is mandatory for each patient. That's and also Shermer test for example, and Rosenberg. This is routine for, and also the questionnaire. Questionnaire is very important for the patient also.
Correct, true, very true. Anything anybody else wants to add or ask?
So I think the most important point what he made was that we should not forget that we have the option of putting in a phakic IOL.
Yes,
Yes.
of course.
If you have a patient with ocular surface disease and it's likely to persist, then I think choosing a implantation of ICL is
Yes.
much better, because no post-operative dry eye, and you don't change anything in the cornea in terms of, because whether you do PRK, LASIK or SMILE, you do see an initial dry eye for the first few months. Although, like what you mentioned, that you see maximum with LASIK because you're cutting a flap, maybe the lenticular extraction because the anterior cornea, the nerve endings are preserved.
True, very true. Thank you so much, Dr. Medhat.
And once again, our apologies because we were not aware of the program that we had.
I think someone in the audience has a question.
Yes, I think
So,
gentleman has a question for you.
so someone has a.
Have you done any kind of refractive surgery on the patient of those people who have gone through the under treatment of myopia control intervention, and how does the contrast impact on that? Somebody has already gone for the myopia intervention, like they have gone through the low dosotropy in spectacle lenses and all these things, and then you have done the LASIK surgery. Have the impact on this therapy on the
So he's asking you whether any treatment that was done for control of myopia, like atropinization, does that interfere with your outcomes of refractive surgery? Do you find any relation between the two? Between use of atropine eye drops,
To prevent progression of myopia, if somebody has had it when they were young, will it change anything for treatment?
Sure. Thank you so much, and apologies, really, really sincere.